concentric fractures.
Thank you, doctor.
Thank you.
Any questions? Yes, please.
Harshad, very well presented. One question. I did see your X-rays which shows a big lesser trochanter lying away from the, even after reduction, and your implant is held. Two screws I found, one of the screws is having a hold in the head, and rest two screws are in the neck only. So I'm just not being able to understand what is the ideal fixation with this construct, what you considered in your study, that what you define as a good surgical performance.
Sir, good surgical performance is a good reduction preoperatively, and then fixation with screws which have adequate length, so that they can reach the center, at least the center of the femoral head, and the screws should be converging. The implant, the holes which are for those proximal locking screws, they are at fixed angles. The topmost being 95 and the lowest being 135 degrees. So they should ideally converge within the femoral head and neck. So that is the ideal configuration of this fixation.
Next question.
Harshad, you have said out of 5 unstable fractures, 3 had very poor results. So it amounts almost 60% poor results. Would you still recommend for unstable fractures this plate?
No, no, sir. No, sir.
This is not recommended. Absolutely. This message should be very clear.
Yes, sir. Yes, sir.
Excuse me. My question is, what you did with the broken screws? What redo surgery you did in the failed cases?
Sir, basically, radiologically, even though the third patient which I showed, radiologically, even though he had broken screws, he was doing quite well, and he did not want to get any surgeries done. And basically, we did not want to do any harm. For the third patient, we did not suggest surgery.
No, they will die without surgery also. That is not a question.
Well, for the fourth patient, can I just finish? For the fourth patient, we wanted to get the implants out because he was doing functionally as well. He was doing very bad, so we wanted to get the implants out and go for a hemiarthroplasty, but the patient was not willing.
Mr. Yadav, sir.
Sir, 13 out of 23 failures.
Yes, sir.
Do you think it's because of osteoporosis? Do you think it's because of technical failure? Or do you think it's because of bad implant?
Sir, it's difficult to give numbers, but all 3 factors, as the last slide shows, all 3 factors play a role.
Yeah, Professor Sandhu.
Sandhu from Amritsar.
Sir.
Sir.
First, I appreciate you for speaking the truth,
Sir.
which is rare in case of various implants used, and I appreciate that.
Thank you, sir.
Secondly, if the fracture does not unite, whatever may be implanted, it will fail. Third, the fracture itself. Everybody knows it is a problem fracture, particularly where there is extensive comminution in the region of trochanter. And every implant is like to be a failure. The previous speaker who said, who has presented on cemented bipolar prosthesis or cemented total hip, they have an option in such cases.
Yes,
Not
sir.
that they should be applied in every case, but they have an option. My feeling is that every patient must be assessed on its own merits, depending upon the anatomy of the fracture, the patient's general condition, his life expectancy, his capacity to cooperate in the posterior period and look after the implant or the prosthesis. These should be the criteria.
Thank you, sir.
And I appreciate you for speaking the truth.
Thank you, sir. No more questions. Time is up. Next speaker is Dr. Sameer.
Good morning, one and all. Today's talk of discussion is early outcome of 30 operated cases of acetabular fracture. All principles are still gold today. There is no conflict of interest in my study. There are advantages. Every field of orthopedics has acetabular fractures in management. Still, there are certain principles which are evergreen from the beginning of operative era of acetabulum. And in this study, we tried to understand them. Total number of patients were 30, and open reduction and internal fixation done of the 32 hips within 1 week of injury, and two patients were lost at the final follow-up. Inclusion criteria. Patients were aged between 18 to 65 years of age, male and female both were included, and the patients who were, has completed minimum 6 months after the fracture event were included. Unilateral and bilateral cases included, and fractures with posterior hip dislocations are included. Patients exclusion criteria. Patients aged less than 18 years or more than 65 years were excluded, while congenital anomalies, pregnant patients, pathological fractures and uncontrolled diabetic and psychiatric illnesses patients were excluded. All the patients were managed initially with the standard trauma care patient, and patients were followed between 6 months to 2 years after operation. Fractures were classified according to classification of Laternal and Judeth's classification, which includes early elementary fractures and associated fractures with 5 subgroups in each group. 31 patients were operated using single approach, either one of Cocker, Langenbeck, ilioinguinal or extended iliofemoral, and the goal of operation was to achieve an anatomical reduction of the articular surface of the acetabulum. Post-operative traction was not used in any of the patients, and no prophylaxis was given for the heterotopic ossification, and immediate ankle mobilization was started in the post-operative period. Complications in the form of immediate post-operative period and final follow-up noted, and at the follow-up FP view and standard Judet views were made, and the clinical results were graded according to the Obing scale, which includes pain, walking and range of motion. Mean age group results. Mean age group in the study was 36 years, and the patient's age was a significant variable with regard to accuracy of the reduction. Rate of anatomical reduced fracture decreases after the age of 40. In our study, 57% patients with age more than 40 had an anatomical reduction as compared to 78% of the patients which were less than 40 years of age. Most common mode of injury was a road traffic accident, and the posterior wall fracture was the most common type of the fracture. And our study is supported by the other studies. Results according to the fracture type. Most common fracture was the posterior wall fracture, while transverse posterior wall fracture and T-shaped fracture was not present in the study. Hips operated within 7 days have better score, and for a given fracture, degree of anatomical reduction are directly associated with the excellent and good outcome. Results according to the reduction. In the elementary fracture, reduction was very much easier than the associated fracture, and the posterior wall fracture, anterior wall fracture and anterior column fracture, we were able to achieve anatomical reduction in all the cases. Results according to the complications. There was no infection and or heterotopic ossification, while the arthritis was the most common complication. One patient had the immediate post-operative sciatic nerve palsy, which partially recovered only, while the 2 patients had osteonecrosis. Results according to the fracture type. Posterior wall fracture has, although the posterior wall fracture had complete anatomical reduction, but according to the outcome, only 5 patients had the excellent outcome, while the 3 patients had the poor outcome. Overall grading was the excellent result was found in 40% patients, good in 30%, while the fair in 10 and poor in 20% of the patients. Conclusion. Acetabular fractures are seen in the younger age group following the high velocity injury, and proper radiological assessment of the fracture type is necessary to to outline the proper line of management, which is mandatory for the better outcome, and operating surgeons should have the thorough knowledge of this region. With appropriate pre-operative planning, intraoperative execution of it and careful post-operative monitoring, it helps us to get a good outcome in this set of the fracture. And increased rate of anatomical reduction and decreased rate of the operative complications should be the goal of surgeon. Few studies. In 1998, this paper, it was suggested that we should outline the proper pre-operative planning, use the single approach as far possible, and operative reduction anatomical should be the must. Another study in meta-analysis, it was shown that the operation to obtain the most accurate reduction of the fracture, which is possible with minimal surgical approach, is both are related to improved outcome. In this case, it is a good case of our study. A patient had the posterior wall fracture with which we were after post-operative period we were expecting average outcome, but the protocol was used was very good. Early operative period and early rehabilitation was done, and the final outcome was very good. Patient was able to achieve its pre-injury vocational. Limitations of the study. There are only few numbers of the patients, which is small number of patients, and it is not a randomized trial, and a small period of follow-up is available only. take-home message. It is a fracture of the young to middle-aged people. We should diagnose the proper subtypes properly for the expected outcome. As far possible, we should operate within 1 week of the period. Use the single approach as far possible. Anatomical reduction is must for this fracture, and complications do occur. So we should inform the patients, and still full rehabilitation is possible. Thank you.
Thank you, doctor. Any questions? If there are none, then thank you. And we call next, the last speaker, Dr. Bidwai.
Thank you, sir.
Hearty good morning to the respective faculty and dear delegates. I would like to present today a comparative study of DCS and PFN in the management of subtrochanteric femur fracture. Starting with the definition, subtrochanteric fractures are defined classically as fracture extending from the lesser trochanter to 0.5 centimeter below it. Or some authors have classified this fracture as the one that extends from LT to the isthmus of the diaphysis. The most commonly used classification is the Shinshama classification, in which this fracture has been divided according to the number of fracture fragments, along with the fracture configuration, the line of the fracture displacement. The recently used is the AO classification, which follows the line of a diaphyseal shaft femur fracture with addition of 0.1 to the subtype. The problem of fixation begins from the fact that the anatomical site, which is a unique anatomical site at the transition zone between the proximally cancellous bone and distally cortical bone, which creates a concentration rise and a stress rise at that site, which leads to more comminution. As in more comminution, there is more vascular insult, and after obtaining a stable reduction, the bigger problem is redisplacement due to the muscular pull due to the iliopsoas and the adductors and the abductors pull around it. Seeing this problem, the choice of treatment for a subtrochanteric fracture is internal fixation. The two modalities mainly used are extramedullary device and intramedullary device. The prototype of extramedullary device in our study was a dynamic condylar screw, and a prototype of intramedullary device in our study was a proximal femoral nailing. The aims and objectives were to compare the results of proximal femoral nail and dynamic condylar screw in the patients of femoral subtrochanteric fractures. Objective was to compare the radiological union in both the groups, to compare the clinical and functional outcomes, and to compare the complication in both the groups. 10 subtrochanteric fractures were treated with DCS, a dynamic condylar screw, and 10 were treated with PFN at Guwahati Medical College and Hospital. The mean age of all the patients was 48 years with a mean of the range of 20 to 80 years. Mean follow-up period was 8 months for DCS and the PFN group. Comparing the fracture reduction, it was seen a good to acceptable reduction was found in approximately 70 to 80% of the DCS cases and 60 to 70% of the PFN cases. And a poor reduction was seen in 20% of DCS and 10% of PFN. When this values are compared, the difference was not found to be statistically significant. In comparing the time when the full weight bearing is given in a post-operative period, the mean or average time for full weight bearing in a DCS was found to be 12.6 weeks, while in PFN this came out to be 8.3 weeks. When this difference was statistically measured, the difference was significant, which may have bearing on the end results. In comparing the union of the fracture and seeing the time at which the different fracture unite, the mean for PFN was 14.8 weeks, while for a DCS it was around 16.2 weeks. Again, when this was calculated, the difference was not found to be statistically significant. In comparing the complication rate in both the group, it was studied as intraoperative complication and postoperative complication. In one case of PFN, we encountered an intraoperative unicortical fracture shaft of femur. It was detected in the immediate post-op period but the subsequent post-operative was uneventful as patient had delayed weight bearing and he healed from that. In the case of DCS, there was one case of superficial skin infection found at the time of stitch removal, and it healed with a longer course of oral antibiotics. Finally, coming to the functional results using Harris Hip score, excellent, it was divided as excellent, good, fair and poor. Excellent to good results are seen in 70% of the cases, while in DCS group the excellent to good results are seen in 60% of the cases. Again, this difference was not statistically significant. So, while concluding, PFN, which is a new implant in our setup, provides comparable results in terms of fracture union as well as functional outcome when compared with DCS. The functional outcome is more influenced by the quality of the fracture reduction obtained rather than the type of the implant used. PFN allows proximal femoral nail allows early weight bearing in the post-operative period and enhancing the rehabilitation. This fact or asset could be attributed to the fact that PFN being a load sharing device, so the stability will be more, it has a shorter lever arm, so the abductor power will be more, and it being a closed internal nail, the amount of soft tissue dissection will be less. So it will have a better possibility of early weight bearing in a post-operative period. The drawback of this study, what can be done better is a randomized study when a follow-up of long duration and a large sample size will help to throw more light on evaluating this complex fracture. When the results of this study were compared to other studies, it was Pajarino in 2008 was the first to tell about the use of PFN as a closed intramural nailing in a subtrochanteric fracture. And comparative results were found when Lagari was the first to compare DCS with PFN, and he had found equivocal results with DCS and PFN, but found better rehabilitation with the PFN case. And this was suitably correlated with our study. Thank you.
Any questions? Sir.
Doctor, I think you are comparing apples and oranges. When you said there was a good result, good reduction, both PFN and DCS gave you good result. But when the reduction was poor, it didn't give you a good result. I think basically it is a reduction. You are putting it to the implant. I don't think implant has anything to do with it. The reduction, and I don't understand why you couldn't reduce when you were doing a DCS. I think that is something which is a myth, which is that you cannot reduce it by a closed method, you have to do an open method. But unfortunately, it wasn't done.
Thank you, sir. Thank you, doctor.
I'm Dr. Mandam from Delhi. Have you ever used bone grafting in subtrochanteric fractures?
Sir, in one case of posterior middle comminution, in that time one case of bone grafting was used. In primary, it was in the primary procedure itself.
I, having bit of long experiences with this, bone grafting is a must in subtrochanteric fractures.
I'm really sorry, my statement is not a question but a request to everybody in the house. I missed one statement in my presentation. I wanted to request all the participants in the house and representative of all the associations to initiate the hip fracture registry so we can all come up with a national hip fracture database, because this is the need of the hour and it is being talked about in almost every country. The main need is the hip fracture database. I would request to...
Thank you, you can do it afterwards. Yes.
Thank you sir.
I have just been informed, thank you doctor. Sure. We have just been informed there is little change in the program and one more lecture has been added to this session. So I call Dr. Jefferson George.
Honorable Chairpersons, faculty of the dais and friends, I will speak on the efficiency of the Philose locking plates for the management of unstable proximal humerus fractures. Firstly, proximal humerus fractures, they form 3 to 5% of all fractures. 3 and 4-part fractures are unstable and need internal fixation. The treatment techniques, they included percutaneous pinning, suture fixation, tension band fixation, iron nailing and shoulder replacement. The locking plates provide angular and axial stability. They lessen screw toggle and pull out. We enrolled 32 consenting patients, of which 13 males and 19 were females with unstable proximal humerus fractures treated from June 2011 to May 2013. They were aged from 20 to 70 years and were evaluated for clinical, radiological and functional outcome following the Philose plate fixation. We included closed 2-part fractures with humeral shaft extension or 3 or 4-part fractures having a tuberosity displacement enough to cause significant subacromial impingement. We excluded skeletally immature patients, displaced 3 or 4-part fractures with significant comminution, patients with distal neurovascular deficit and pathological fractures. So fracture distribution. Indications for surgery were surgical neck fractures with an angulation more than 45 degrees, fragment displacement more than 1 centimeter, a GT displacement more than 0.5 centimeters, shaft displacement more than 1 centimeter, and a destruction of the medial metaphyseal column and an intra-articular step-off of more than 2 mm. Surgery was performed in the supine position with the standard deltopectoral approach, and periosteal stripping was kept to a minimum. Then the rotator cuff, capsule and subscapularis muscle tears or avulsions were repaired meticulously. Immediate passive mobilization was started post-op. Patients were assessed clinically, radiologically and functionally using the Constant-Moly shoulder score at 6 weeks, 3, 6, 9 and 12 months. Then our results, patients were followed up for a mean period of 13.85 months. RTS constituted 65% and falls accounted for 35% of fractures. Mean time to radiological union was 14 weeks. Mean constant shoulder score was 71.35 points and was categorized as good. Varus malalignment followed by varus collapse occurred in 2 patients who had uneventful good functional recoveries. Then restriction of shoulder movements occurred in 2 patients which improved with physiotherapy. Subacromial impingement occurred in 1 patient which improved with time and the plate was removed after the fracture united. There were no wound infections, screw perforations, vascular injuries or osteonecrosis of the humeral head, and none had axillary nerve palsy pre or post-operatively. So 45-year-old patient who sustained a 3-part proximal humerus fracture after a road traffic accident, and this is his X-ray post-fixation. This is function at the end of 1 year. The complications include 65-year-old female who had a proximal humerus fracture following a slip fall at her home. Following fixation, when she had varus malalignment and varus collapse, which went on to unite, is a function at 4 weeks and a function at the end of 1 year. This is another complication which we encountered in a 58-year-old female who fell from a 2-wheeler and sustained proximal humerus fracture. Following fixation, we noted subacromial impingement. This is a function at the end of 6 weeks with restriction of abduction to 60 degrees. And this is following implant removal at the end of 1 year when she had improved abduction. These are the constant scores at the last follow-up visit according to the fracture type. Mean constant scores in various studies. These are the complications in various studies. When subacromial impingement occurred as a result of far too cranial positioning of the plate, commonest complication encountered in the studies was screw perforation. Hertel correlated viability with specific radiographic signs like metaphyseal head extension less than 8 mm, medial hinge disruption more than 2 mm, and an anatomical neck involvement. Erhardt, he suggested the placement of the inferior-medial calcar strut or the kickstand screw, which has a positive effect in reducing varus collapse. Tingart suggested that a combined cortical thickness of less than 4 mm was associated with significantly low bone mineral density and should not be considered for ORIF. Kokaki recommended primary hemiarthroplasty in displaced 4-part fractures in osteoporotic bones. Munot recommend packing the humeral head and shaft with bone graft or bone substitutes when the bone is osteoporotic. And Matsuda suggested augmentation with PMMA cement as an option in osteoporotic cases, but we have no experience with this technique. In conclusion, the good news is that most fractures can be treated by closed methods, especially in elderly. However, young patients with displaced fractures need osteosynthesis. All 3- and 4-part reconstructible fractures should be treated with ORIF even in elderly. Arthroplasty should be reserved for non-reconstructible fractures, osteoporosis and comorbidities. The option of arthroplasty should be available when attempting ORIF in difficult fractures, especially in elderly. Operative treatment demands increased surgical competence, strict adherence to locking plate principles, and rotator cuff should be given due respect when fixing fractures. All said and done, good surgical results can only be obtained by vigorous physiotherapy imparted by an expert team and strong motivation from the patient side. Thank you all for your patience.
Thank you, doctor. As the time is up, we will not allow any questions on that. And with that, we finish this session of free papers. Thank you.
Thank you.
The most esteemed section of this conference, and I'll request Dr. Maria and Dr. Kapoor to take their place at the dais. Good morning, sir.
Good morning. Good morning. A housekeeping announcement. The 2014 IOACON registration has been opened, and there is a huge incentive for those who actually book during this conference, as I have been advised by the organizers. So please visit the stall near the registration counter for next year. So the dates that they have put up are 19th to 22nd of November.
Very good morning. I think there is a small mistake in the printing. In any case, we invite Dr. D.K. Taneja to give his lecture to the station.
Chairperson, ladies and gentlemen, at the outset, I would like to thank the Indian Orthopedic Association for giving me this honor of giving a eponymous lecture in the name of a legend of orthopedics in this country, no other person than Professor B. Mukhopadhyay. Professor B. Mukhopadhyay, born on 1st January 1916 in a very modest and poor family. Dr. Mukhopadhyay was a brilliant student who never stood second in his life. On his scholarship, he went to a medical college and got distinction in all the subjects and a Wheeler's Medal. He joined Indian Army, went and did his fellowship and MCH from England, came back and joined the Patna Medical College and became the first professor of orthopedics in whole of the Bihar. He established one of the busiest practice and got patients from Nepal and other far-off places like Burma. Probably he was the busiest orthopedic surgeon of his time. In spite of that, he always had time for his family. His three sons, all brilliant in their own way. One joined the Indian Foreign Service and is now an ambassador. One is a leading lawyer in the Supreme Court at Delhi. And of course, you all know John Mukhopadhyay, a leading orthopedic surgeon of district. He always cared for his students and saw to him that their career is taken care of. He was always looking for the talent in the Indian Orthopedic Association. And his greatest contribution to this country was that he established orthopedics as a separate specialty against much resistance from the general surgeons. He, along with Dr. B.N. Sinha, Dr. Karam Singh Grewal, Dr. A.K. Gupta, and 10 other orthopedic surgeons were responsible for founding this Indian Orthopedic Association. He was the first secretary. He was the first editor. He was the founder chairman of the Orthopedic Foundation of India. He was the chairman of ELIMCO. He was the president of Indian Orthopedic Association and Association of Surgeons of India. He became the director of health services of Bihar. He was the founder fellow of the National Academy of Medical Sciences, a very high honor which is given to purely on your academic achievement. He was a Dr. B.C. Rai awardee, and he got a very high civil award, the Padma Bhushan from the President of India. And at the age of 80, he authored a book, a age when most of us are sitting in our garden watching the roses, reading newspaper, and enjoying our coffee. He was the first Indian to deliver the Hunterian lecture on 13th October 1955 on an osteoarticular tuberculosis, results of the treatment of 941 cases. At that time, when there was no way to maintain the records, he used to maintain the record all by his own hand. I have seen it myself at his house. And this, his Hunterian lecture, made a sea change in the thinking of the treatment of osteoarticular tuberculosis. He was a very accomplished surgeon. Those who have seen him operate will bear with me. He was a very dedicated and committed teacher, a crusader against the falling standards in the medical education, ethics, and the practice. His favorite subjects were osteoarticular tuberculosis, bone and joint infection, and a neglected trauma, and of course, a clubfoot. He once told me, look, Devin, I might have treated about 5,000 cases by myself, and that must have been the world record. And this is because his subject was very favorite, and one of my favorite subjects has been the clubfoot, and therefore I thought I'll share my thoughts of my 45 years experience, and the title of my talk is Yesterday, Today, and Tomorrow, and my journey of 45 years. Let us look into a very basic things. The incidence of a clubfoot in the Western world is much less than in the developing world. We have a much higher incidence, it has been now proved, and maybe it is a racial, chromosomal, or genetic, or all other factors are we taking into this thing. We always share the agony and ecstasy of treating this clubfoot. Who will deny that when a mother gives a childbirth to a child, and who has got a clubfoot, and there you can always see the tears in her eyes. But within a month or two, when you have treated the child and his feet are plantigrade, you can see the happiness on this child. And these children remain with you all your life, and they share their happiness and their secrets of their life. The clubfoot has been attracted many authors, many writers, and this book of human bondage, which you all must have read, and the hero in this book, Phillips, who has been humiliated because he was a clubfoot, and his dialogue with his mother brings tears into your eyes. In the Madame Bovary, the person who has a clubfoot undergoes an amputation. It has attracted many painters, and you can see these famous paintings in the Louvre at Paris. Kamlesh Tiwari, whom I had treated 27 years back, came recently to me, and I saw he was so happy and so delightful that it gives us a happiness that after 27 years he is so walking well, although you can see some of the hindfoot varices there. The etiology is now, of course, is very much a chromosomal factors play an important role. The mother brought her child, and mother told me, doctor, you treated me, and my feet are not good. Don't treat me, my child, like this thing. And my answer was, I have now a better method to treat your child, and I assure you, you will not get that bad result as you got it in your these things. But we have now the better tool of investigation. We have got MRI, we have got a Doppler, which tells us there is much more to the clubfoot other than the multifactorial etiology. The anatomical facts are much more now clear as on today. We know that there is abundance of collagen in the ligaments, which are responsible and which are stretchable, which can reform on every 5th day. But tendo Achilles has a different thing to speak, and you have to do a tenotomy for this thing. The kinematics is much better clear. We now understand that there is no single axis of motion which exists, and the movements of each tarsal bone involves a simultaneous shift in the adjacent bone like a chain. Like you can see this gear system, if you move one tarsal bone, all other tarsal bone also move on their axis. The growth and development has been talked about, and it is being considered as a dynamic deformity because a damaged growth nucleus and a tendon lengthening retards the growth of the foot, whereas a repeated stretching and relaxation stimulates the growth of a foot. Lot of things had been talked earlier in 1988 and 1991, and we talked about that there is no standard method of classification. Scenario has changed totally as on today. There are many prevalent classifications, out of which the Miglo, Pirani, and International Clubfoot Study Groups has been well universally accepted, and this is a photograph recently when I met Pirani in Prague. Lot of things has been talked about the analytical radiography. When George Salmon published his article in 1977, we all started doing the analytical radiography, and we thought it was very important to do this thing. But it has now been accepted that the non-accurate replicability or inter and intra-observer variation and pitfalls are there. Therefore, this is not a standard method of evaluating your fit. However, ultrasonography, this parameter shows a much significant correlation, and sonography is certainly superior to the radiology. There is these days talk about the pedobarography. The pedobarography is a technique where you measure the pressures under the feet, and thereby you can evaluate whether your foot has been clinically corrected or this thing. But it is, that finding has been questioned, and therefore it is not a very popular method of monitoring. From 1968 to 1988 that I have been doing the clubfoot, the things were very different. From 1988 I got more interested and established the clubfoot clinic at Riva Medical College. We started going to different camps and picked up the patients of clubfoot to our clinic and wrote it up, our experience, in the World Health Forum. And in 1992 when I came to Indore, I started and dedicated a clinic which I called it as Dr. B. Mukhopadhyay Clubfoot Clinic, which is still running, where we have 573 cases running. The treatment of a clubfoot, in my opinion, has always been a very challenging. And the standard method that I had been practicing was a kite method of manipulation. We looked into the original paper of the Hiram Cat, which he wrote in 1930. We also looked into the original article by the Ignacio Poncetti, which he wrote in 1950, both in America. And we found that there are similarities on 17 points and dissimilarities on 12 points. And since the kite method failed to understand the proper functional anatomy in the normal foot and the club foot, and therefore this method failed. According to Brockman, only you could correct such patient by this method in 30% of the cases. However, in 2001 we reported that it is not so. If you are persistent with these patients and do a correct manipulation, you can get a very good result. And we wrote it up in the Indian Journal of Orthopedics that really are the resistant clubfoot, really resistant or not. But however, the revolution has come by the work of Dr. Ignacio Poncetti. We all know about it. But no method has free of any problem. Many pitfalls, you all know that, during manipulation, during casting, during tenotomy, and during braces, which has a direct impact on the result of this thing, out of which the casting and the bracing are two very important things. But very important thing is, which has come up now recently, that it works in the older children also. Mark Winde, who was the second to Dr. Poncetti in Iowa, USA, has said that you can do it up to 2 years. They have shown the cases which is even up to 9 years. Julian, who has shown that you can do these cases up to 11 years and 12 years. And Shah Alam from the All India Medical Institute has shown he has done cases up to the 7 years. This girl, Alina, came very recently to us, who had never been treated till 6 years of age. We said, we'll try this method. And you can see that at 6th placer, her feet has become fairly corrected. So this method works. We have been doing a lot of surgery in this clubfoot. Posteromedial release, tendo-Achilles lengthening, partial subtalar release, complete subtalar release, Cincinnati operation, and whatnot. Maybe we might have spoiled more than what we have treated. And all these surgeries, most of the results that you look into the literature show the results are not very satisfactory, and hardly about 50% cases you can get a good result. Every foot we learned has its own personality. You have to take a decision on the table. You have to have a a la carte approach, and that is what they say. Does the surgery make the foot stiff and painful? Lots of people have started talking this thing. I think it is an over-exaggeration of the statement, and I always have questioned this thing because, in my experience, if you have a foot which has got an indication for surgery and you have done the surgery well, I am sure the results are fairly rewarding. Here is a patient who has got 11 years follow-up. You can feet were treated by surgery, fairly good looking feet. This other patient, 14 years follow-up, you can see the feet are fairly good. Patient is happy, we are happy. Here is another patient, 16 years follow-up. You can see the feet who have been very well corrected by surgery. And this is Abhijit, 24 years follow-up. You can see that patient has got a hind foot varus and forefoot adduction, but he is managing very well. So these are this thing. However, with the time, the incidence of surgery has drastically declined, and this is in the experience of everybody. We started with a conservative treatment and came to a radical release where we used to do a complete subtalar release from both medial, posterior, and the lateral side. And now again we are purely on the conservative treatment. That should make us very happy that this is one place where from an operative we have turned over to conservative. Otherwise in orthopedics, conservative word has totally almost disappeared. After treatment, still few people get recurrence. What do I do about it? And this recurrence is mostly between 3 and 4 years of age because of the abundance of the collagen. And the treatment, in my opinion, is that you must do a remanipulation and you can get an excellent correction. And if need be, you can do a tibialis anterior transfer. And this is a child, Raghav, whose mother is a physiotherapist. After a beautiful correction, she refused to give an abduction brace. She said, I am a physiotherapist and I can correct and keep the child stretching and my child will be all right. The child got a recurrence. We put her back into the plaster and the child came only on 29th December, 4 days back, and you can see the feet has been beautifully corrected. There are group of patients where the treatment is always an enigma. Thanks to Dr. B.B. Joshi and Professor Elise Rao, who talked about the tissue growth by the distraction. And we also made some modification into the JESS method where we loaded them with different types of spring to create a dynamic force and treated this patient. A 9 months old patient of arthrogryposis, you can see that what a beautiful correction has been done by the JESS method. Both the knee and the ankle deformity has been corrected. Arvind, at 7 years follow-up, who had undergone surgery, very bad recurrence, has been treated by the JESS, and you can see the results. The patient has got even the overcorrection because also the patient has undergone a complete subtalar release operation. This is another patient, Balwant, totally a neglected clubfoot, again treated by the JESS method, and you can see the 10 years follow-up that you can always get a correction. Pallavi, who had undergone 2-3 surgery, had a bad recurrence. This is at 10 years, and this is at 21 years. She came recently. You can see with the nail polish that she has been married, has got a child, and lives now in Baroda. We wrote it up in the Journal of Foot and Surgery about the spring distractors treatment in a club foot. In my opinion, the treatment of a neglected club foot is entirely cosmetic because if you go into the literature and go into the internet and see, the many people with a club foot had been playing football, baseball, every game they can play and they can do this thing. What is important is that this deformity is causing them a lot of humility and they cannot get into the government services. And this is one such example. You can feed how the feet can be beautifully corrected. So we try to work it out, a correlation between the clinical and radiological corrections, and we picked up 43 feet in 32 patients. And these are the patients, 6 years follow-up, 4.5 years follow-up, that they have got some deformity which is persisting. Sher Bano, who had you can see the talocalcaneal angle, the parallelism is persisting. There's a severe deformity in the foot. And when we worked it out, their functional scoring, we found that lot of patients, majority of them who had a deformity, but still their functional score was extremely very good. This girl had a forefoot erection and mild hindfoot varus. Still she was very happy, no problem, running around. The parents were happy, the child was happy. We also found it out. When you have a foot where you have corrected it clinically, but still radiological correction was not there, and this amounts to 25%, and we labeled it that these are the 25% which needs a very close observation, and what we call them as a foot at risk. The maintenance devices were very important. We used the Dennis Brown splint, we used an ankle foot orthosis, we used the Orfit brace, we used the Easy Foot brace, polypropylene bases, but never have been happy till we have now found a Steenbeck by what the Ponseti has given. We also found it out that the Robert Jones shoes that we were supposed to be giving these patients were not very effective. We made some modification and called them an indoor shoe. You can see a cut from the posterior side, which shows whether the heel is on the sole or not. We had an ankle strap to keep the heel touching the sole. We also had a forefoot strap to keep the foot into abduction, forefoot. And this, about this, the role of this shoe, we wrote it up in Indian Journal of Orthopedics, and we did that how it is important, this thing. At total, from 1988 till this, we have 1,265 feet treated. At Arihant Hospital, where now I work, we have a 173 patients registered and 249 feet. And in majority of these cases, you will see that 193 patients has been treated by us by a Ponseti technique, and where the majority of them had a severe deformity and 73 had mild to moderate deformity. And this Pirani scoring after treatment that improved drastically, and even when we tried to put the 50 feet who had a long follow-up onto the ICFG score, we found the majority of the patients had an excellent result. This is the one patient, Ishan, 4.5 years after treated by the clubfoot. You can see how beautifully feet has been corrected. Another patient, 6 years follow-up, you can see how the feet has been beautifully corrected by Ponseti. Another patient, 7.5 years follow-up, you can see he has got some deformity of the forefoot adduction which has not been corrected, and there is sometimes the overcorrection you can see on the right side, and there is at hind foot level. This is another patient, Kuldeep, 8 years, and you can see that there may be some deformities persisting, but these children have been extremely happy. So when we re-look into our treatment, we found that those treated by the conservative methods, their feet are strong, they are supple, and they are pain-free, and patients are happy. However, those treated by surgery, they are not too bad. There is some stiffness, there is some pain, but there is a scar, and this is what the main outcome of this patient is. We also, when I was working in the medical college in Indore, I obtained a computerized gait analysis machine, and we gave that let us study the gait in these patterns, and we published it in the Indian Journal of Orthopedics, and our conclusion was that howsoever beautiful correction you make, the gait parameters do not reach to a normal level. In 2001, I gave my kidney memorial oration on these things. And as on today, what is the difference between yesterday and today? The etiology was not clear. Today we are absolutely clear. The pathoanatomy was not properly understood. Today it is far better understood. Kinematics, there was no concept. Today we have a full concept of the kinematics. The kite manipulation, and today we have a Ponseti method and we have a French method. There were a lot of surgery and extensive surgery we were doing it. Now we do surgery very minimal, and just and the Lilizerol is the treatment of the choice. Very high recurrence rate yesterday, and today we find very few patients undergo a recurrence. And there is no good brace was available, but there is a very good brace available now. So, what is the future and what is the tomorrow that I am looking into this thing? So for that, I have a dream. And my dream is that we have now eradicated polio from this country, thanks to the government, thanks to the NGOs. Now what about these children who are born with this clubfoot, who cannot become productive to our country? who are being humiliated in the society, that we all owe something to them, and you do not want them to grow up and walk like this, the child is walking about it. A country where there is a gender bias, the girls are not brought to the clinic for the treatment, and therefore, I think you have something. A country where 70% population is living still in the rural area, but there is a revolution in the communication. Everyone has gotten a mobile phone, and mobile phone has gotten a camera into this thing. So my concern is that every year you are having 40,000 new patients of clubfoot being born in this country, out of which the 28,000 are in this rural area. So can't we have some type of a tele-rehabilitation program? And because we all know that if an early intervention is done from day one, the clubfoot can be cured within a month to 2 months' time. For that, what I have some national vision based on my experience of last 45 years, and for which the Indian Orthopedic Association can play a very important role. The President and Secretaries are sitting here, and President-elect is also sitting there. What Indian Orthopedic Association can do? Form a clubfoot study group. Involve the government, the NGOs, and the public. And the clubfoot awareness campaign for the local DAIs, Anganwadi workers, and support a tele-rehabilitation program and full use of IT technology. This has come up in a big way, and tie up with an organization like Cure International. I have just to show you that if you can have a child born, and everybody can take a photograph of that from different angles, send it to a center on the internet, those photographs, and prepare a prototype in a computer, prepare a silicon model, and try to prepare a custom-made, computer-generated dynamic brace which works on the principle of an upon SETI. Can this concept work? I'll show you that it works. We, with the help of the engineering department at Indore, we've made this device. We are planning, and this is a concept which I'm giving, and which in my opinion seems to work. This, and with this you will have a minimal visit to the hospital, and you will have minimal use of a plaster. Maybe a day may come when the plaster will go out in the treatment of a clubfoot. There are many community-based rehabilitation programs all over the world. We can have these type of program with the help of Indian Orthopedic Association. Lots of my students from 1989 till 2013, whom I motivated to do their thesis in the clubfoot, or many of them are sitting here. I am very indebted, grateful to them, who have always been with me in my journey. And to all these my children and their parents, who has always been very patient with all the time when we have been treating these patients. But this challenge of clubfoot is not over. It continues. The patient with the clubfoot come in different way, different forms, and this always throw a challenge to you. Okay, doctor, now you treat me and let me see what your 45-year experience can stand. Now, here is a man, Dr. B. Mukhopadhyay. On the other side, you see another legendary of the orthopedics of the world, Sir Robert Jones. Robert Jones did establish the orthopedic specialty in Great Britain against much resistance of the general surgeons, and he was the man who was responsible for forming a British Orthopedic Association. Dr. B. Mukhopadhyay, for him, Robert Jones was his role model. Same role Dr. B. Mukhopadhyay played when he came to India. Both loved treating clubfoot, both wrote extensively on clubfoot, and no wonder Dr. B. Mukhopadhyay is called as a Robert Jones of India. At this stage, I am reminded of a very famous couplet of Allama Iqbal, which says, "Hazaron saal nargis apni benuri pe roti hai, badi mushkil se hota hai, chaman mein didawar paida." I think this is what he wrote when he has a man like this in his mind, because person like Dr. B. Mukhopadhyay are born once in lifetime. With these words, I dedicate this lecture to Professor Dr. B. Mukhopadhyay, a visionary of this country. Thank you, ladies and gentlemen, for your attention.
Though it is not a customary to speak something after this type of lectures, our heartiest regards and congratulations to Dr. Taneja, who is a close associate of Dr. Mukhopadhyay. So am I. I was very close associate to Dr. Mukhopadhyay. So it is wonderful for the new generation of orthopedic surgeons. They should know two persons in India. One is Dr. B.N. Sinha, second is Dr. B. Mukhopadhyay, who has born, they are the parents, not father or mother. They are parents, both persons are the parents of Indian Orthopedic Association.
Thank you,
and
sir.
one thing I
thank you,
can
sir.
remember, which probably missed, after Dr. B.N. Sinha retired from Indian Medical Council, Dr. Mukhopadhyay was took over the Indian Medical Council. Alone, both these people alone has managed Indian Medical Council, when at this stage today Indian Medical Council is in a bad shape. Another thing Dr. Mukhopadhyay told me...
Sir, please. Sir, thank you very much. We have to move on, sir, if you will excuse us. Thank you, sir. Very kind of you. And gentlemen, we are grateful. Thank you, sir, to Professor D.K. Taneja. Briefly, he post-graduated from the Lucknow University, is the past president